Okay, so one of the most frequently asked questions I get on my TikTok account, on any social media platform that I post on about mast cell activation syndrome, in my experience, is tryptase levels. Everybody wants to know. And one of the highest or most often quoted percentages that I see is that only about 30% of patients with Mcas actually show elevated tryptase, and the rest of us should be diagnosed clinically. I personally was diagnosed clinically after 15 years. So I never once showed elevated tryptase. I did, however, meet the rest of the criterion, and we're going to get into that as quickly as we can in a 10-minute video. I will be following up with posting this video to YouTube with the reference links, and then I am also going to put together a compilation of Mcas videos so that you can watch them all on my YouTube channel, because I get asked all the time about Mcas, and I'm answering the same questions over and over. I don't have playlists yet on TikTok, so this is how we're gonna do it. Okay, so first we're going to define the difference between mast cell activation syndrome and mastocytosis. This is from healthline.com. Mcas occurs, mast cell activation occurs when the mast cells in your body release too much of the mediator substance that causes allergy-like symptoms. Mastocytosis occurs when your body produces too many mast cells and is a type of primary Mcas. These cells can continue growing and tend to be overly sensitive to activation and mediator release. So there is a definitive difference. And yet doctors are using the same criterion to try and diagnose both. That's why so many of us get missed. All right, so we've known about mast cells since 1980. That's important, okay? Because for some of us, 1980 was our childhood, okay? So that's important to note. The explanation for why some patients would have unexplained flushing or anaphylaxis would then be an abnormal sensitivity of their mast cells to activation, rather than, for example, an increased sensitivity to histamine. So what breaks down here is the patient may be referred for an evaluation to determine if there's an allergic basis for the presentation, and that's always smart. However, if this workup is negative, it is then logical to consider the patient may... So in the diagnosis for Mcas, patients with such signs and symptoms of flushing, itching, unexplained systemic hypotension, unexplained gastrointestinal disturbances, and unexplained fluctuations in blood pressure usually are tested for allergies. And often that comes back negative. The reason is because we do not always have actual IgE-mediated allergies to the things that set off potential anaphylaxis or anaphylactoid reactions. If this workup is negative, then it is logical to consider the patient might have an unrecognized mast cell proliferative disorder. If an evaluation for systemic mastocytosis is negative, one possibility to consider is that the patient has mast cell-based disease, but where the mast cell population is not increased to number, as would be seen in mast cell proliferative disorder, meaning we might have Mcas, not mastocytosis, which is what doctors are looking for when they insist on checking for elevated tryptase. You see where I'm going with this? The bottom line, according to NCBI, and you'll see this when I post it on YouTube, is that rather the mast cell population is hyperactive. responsive. It doesn't mean that we have too many mast cells. It means that the mast cells we have don't know when to stop responding to things and respond inappropriately to anything. It's a Tuesday, you exist. It's a Sunday, you exist. Barometric pressure changes, you exist. Stress, existence. See where I'm going with this? All right, so here on the NCBI page, they're discussing the fact that there are other criterion under which Mcas patients can be diagnosed who have not met the major or expected elevated tryptase minimum, right? So we're going to get into what those are. Primary includes anaphylaxis with an associated clonal mast cell disorder, monoclonal mast cell activation syndrome, allergic disorders, mast cell activation associated with chronic inflammatory or neoplastic disorders, physical urticarias, and chronic immune urticaria. That's number 1 through 2. 3 is idiopathic mastocytosis. And that includes anaphylaxis, angioedema, urticaria, and mast cell activation syndrome. I was diagnosed with idiopathic anaphylaxis like 9 years ago, you guys. 9 years ago. I want to beat my head against a very hard wall. So look at the notes here. When mast cell degranulation has been documented, may be either primary or secondary. Note also that angioedema may be associated with hereditary or acquired angioedema, where it may be mast cell based, mast cell independent, and result from kinin generation. All right, so I want you to make sure you read this entire article. But patients with systemic mastocytosis, I can never say that word, often have episodic symptoms of Mcas activation such as flushing, lightheadedness, and gastrointestinal cramping. However, there are patients with systemic mastocytosis who have no specific symptoms over years to decades, even if the mast cell burden is high. We therefore propose that the diagnosis of Mcas is appropriate when primary and secondary diseases associated with Mcas have been eliminated and if the criterion in Table 2 are met. Here are the criterion. Table 2, proposed criteria for Mcas diagnosis. Episodic symptoms consistent with mast cell mediator release affecting 2 or more systems. These systems can include skin, urticaria, angioedema, flushing, gastrointestinal, nausea, vomiting, diarrhea, abdominal cramping, cardiovascular, hypotensive syncope, or near syncope, or tachycardia, respiratory, wheezing, nasooscular, conjunctival injection, pruritus, and nasal stuffiness. Also, a decrease in the frequency or severity or resolution of symptoms with anti-mediator therapy. Basically, if you respond to your H1 and your H2s and you felt like crap without them, you might have Mcas. There's a lot more to get into, but I'm on 9 minutes out of 10 for this video. So I'm just going to finish up by reading this portion on this section here on the NCB article, which reads, mast cell activation syndrome for now remains an idiopathic disorder. However, in some cases, it could be an early reflection of a monoclonal population of mast cells, in which case, with time, it could meet the criteria for MMAS as 1 or 2 minor criteria for mastocytosis are fulfilled. Please follow me on YouTube, where I'm going to be uploading these videos with the reference links. And thanks for watching. I'm Chronically Spicy on all channels and platforms. Okay, so one of the most frequently asked Part 2 for Yancy Pants, because no answer about Mcas is going to be an easy one. So we try to summarize as best we can, but I'm doing so with reference links. Make sure you follow me on YouTube, subscribe to my channel. Please like, engage with, comment on every video that you find that resonates with you to help with the algorithm and help me monetize the channel. We are focusing on Yancy Pants' question, which is in relation to Mcas and tryptase. This is part 2. In part 1, I cited an NCBI PubMed article. Now let's go on to the second portion. Mast Cell Hope Learning Resources. Diagnostics and testing for mast cell disease. The symptoms of mast cell disease overlap with a wide range of pathologies, including allergic reactions and allergic conditions, gastrointestinal, gut disorders, endocrine, relating to the hormonal conditions, cutaneous, meaning skin, and a variety of other conditions. And it's these similarities that can make it difficult for physicians to diagnose mast cell disease. Many of us already know this. Diagnosing and classifying mast cell activation syndrome, Mcas. A diagnosis of Mcas is considered when a patient exhibits symptoms that do not meet the criteria for systemic mastocytosis, suffers from recurring and severe anaphylactic-like episodes that involve more than one organ system, has a positive response to mast cell stabilizing or mediator medications, experiences an increase of 20% or greater of blood serum tryptase levels from baseline between 3 and 4 hours after a mast cell reaction. Note, even though it's not stated in this article right now, that last portion is actually not always necessary. It's possible, but it's not necessary. I spoke too soon. The article gets into that too. Hold on. Mast cell hope tip. Do not discount a patient due to low tryptase, as many Mcas patients do not have elevated tryptase. According to Mast Cell Hope, only 85% of patients with confirmed mastocytosis will have elevated tryptase. And the tryptase standard is not 100% definitive diagnostic standard, even in mastocytosis. Yet we're all getting told in the mast cell community that if we don't have elevated tryptase, we don't have Mcas. And mastocytosis is more severe. So screenshot that. Take this link and show it to your doctor. The major physician groups have put forth changes in the diagnostic criteria that do not only consider tryptase. New testing is being developed, and new testing is needed to give us a more measurable and reliable blood test for mast cell activation diagnosis of all types. Thank you, thank you, thank you. That's what we've been saying all along. So this article on Mast Cell Hope is really interesting, and I hope you click on the reference link in the description box when I post this on YouTube on my Chronically Spicy channel, because we're going to be talking, the article talks about monoclonal mast cell activation syndrome, which will not meet the full criteria for systemic mastocytosis. A bone marrow aspirate or peripheral blood test will reveal clonal mast cells with a KIT mutation, usually KIT D816V. Then we have secondary mast cell activation syndrome, or just straight Mcas. Most Mcas patients will experience mast cell overstimulation of an IgE-dependent allergen or substance. Patients with Mcas present with an underlying allergic condition, inflammatory condition, or hypersensitivity. A bone marrow aspirate or a blood test will not reveal the presence of monoclonal mast cells. Idiopathic mast cell activation syndrome. I've been diagnosed with idiopathic anaphylaxis. So, patients with IMCAS meet the criteria for Mcas, including recurring and severe anaphylactic-like episodes that involve more than one organ system. Okay. Positive responses to mast cell stabilizing or mediator medications, anaphylaxis type symptoms. Okay. Yeah, you haven't been saying that all along. All right. Okay, no problem. Not going to lose my mind here. Patients with IMCAS do not present with an underlying allergic condition, inflammatory condition, or hypersensitivity disorder. I'm smiling so I don't cry. Okay? Okay. All right. Yeah. All right. A bone marrow aspirate or peripheral blood test is not reveal monoclonal. But before diagnosing IMCAS, physicians do need to rule out other autoimmune diseases, which is why I often say Mcas is never the first guess. It's usually a diagnosis of exclusion. They have to rule out and test for other things. If your doctor says that Mcas is the first guess, they might be right, but it really shouldn't be the first guess. For a lot of reasons. But we can get into that another time. Then there's diagnosing cutaneous mastocytosis. Not Mcas, mastocytosis. A diagnosis of cutaneous mastocytosis can generally be made with an examination of the skin. The three subtypes of cutaneous mastocytosis include urticaria pigmentosa, maculopapular cutaneous mastocytosis, dark, itchy patches of skin that are tan or brown in color. Gee, has anybody I know seen anything like that on my TikTok account? I have no idea, because I was diagnosed as being told that I had a skin picking disorder and was doing it to myself. Interesting. Yeah. Sometimes learning things makes you want to throw. I don't care if that skipped. How many? Yeah. Sometimes learning things makes you want to throw things. Anyway. Solitary cutaneous mastocytoma, a nodule, papule, plaque, or nodule that is yellow, brown, or reddish brown in color. Diffuse cutaneous mastocytosis. A punch skin biopsy can be used to confirm cutaneous mastocytosis, although it cannot confirm systemic mastocytosis. The skin biopsy should measure 3 millimeters. The major criterion for that last one is multifocal dense clusters of 15 or more mast cells in an extracutaneous organ, an organ other than the skin, such as the bone marrow, liver, spleen, lymph nodes, etc. Minor criteria include bone marrow smears greater than 25% of detected mast cells are either immature or atypical, meaning abnormal size, shape, or color. And for bone marrow and other organ biopsies, greater than 25% of mast cells seen in the biopsy have atypical morphology, abnormal shape, most commonly a spindle shape. So the rest of this article, I definitely can't get to in 1 minute. On the last minute I have out of a 10-minute video, but I will include the link for this article from Mast Cell Hope in the description box on the YouTube video. Please make sure you like, share, subscribe, and if you have any questions, please make sure you leave them in the comment section. Mast cell activation syndrome needs awareness, and I need your help to help get that awareness out there, because there's a lot of us with this condition and a lot of us are undiagnosed. And hopefully the information that I'm sharing here helps Yancy Pants with her doctor's appointment tomorrow. Let's move on to the next one, shall we? See you in the next video. Tryptase levels. Everybody wants to know. All right, so we're discussing for Yancy Pants here the difference between Mcas and mastocytosis. Not for Yancy Pants, but for her doctor. Okay? Mcas occurs when the mast cells in your body release too much of the mediator, a substance that causes allergy-like symptoms. Mastocytosis occurs when your body produces too many mast cells and is a type of primary Mcas. These cells can continue growing and tend to be overly sensitive to activation and mediator release. There's a difference. Mcas and mastocytosis are two different things. That's important to note. All right, now we're going on the last article we're talking about tonight for Yancy Pants and tryptase levels and mast cell activation syndrome. Mast attack, educating people about life with mast cell disorders, written by Lisa Klimas, who is a scientist with mast cell disorder. I'm not sure specifically which one she has. I believe it's mastocytosis. However, don't quote me on that. I just know that she knows what she's talking about. And this site is an extremely important reference for anybody with Mcas or mastocytosis in the United States. Patient questions. Everything you wanted to know about tryptase. Okay, so in the spirit of saving some time here, I did not, and I'm not going to read the entire article, but I've highlighted a few portions of this. And of course, the link to the article is going to be in the description box on YouTube because you can't click any links on TikTok. Why TikTok? I don't understand how that makes any sense, but that's okay because that means I'm going to direct you to follow my YouTube channel, subscribe, like, comment, engage, hit the notification bell, and help me grow my community over there because I'm going to make sure that you have links you can take to your doctors for receipts because it doesn't help when you tell them a random TikToker, said, but they don't care who Pauline is. They do care if you have peer-reviewed articles from PubMed and NCBI and Mast Cell Hope and Mast Cell Action, etc., etc. And that's what I'm sharing with you. Those links are what I'm going to have in the description box on these videos. Okay, so follow along. Let's get to this. There are a lot of reasons why mast cell patients test negative for tryptase. One reason is that a lot of the understanding of anaphylaxis hinged upon the ability of mediators to get quickly to the bloodstream to quickly spread to various organ systems. While this does happen, not all mediators moved at the same speed. Gee, okay, it just kind of sounds like common sense. Tryptase is released from granules as large as complexes with other mediators, like heparin. It takes time for it to dissociate enough to be active. So, if there are things for it to break down in the immediate environment, you will still break them down whether or not you are having anaphylaxis. Eventually, the tryptase that wasn't used up breaking things down gets to the bloodstream. This is where the ideal time to test for tryptase in blood is about 90 to 120 minutes after an allergic event, severe reaction, anaphylaxis. Following severe reaction anaphylaxis, it can take about 2 weeks for tryptase to return to baseline. That's if your tryptase level even raises above what is considered abnormal by your lab. Your tryptase can literally, if this is the lab normal and your tryptase is the baseline here and only raises this much, which would be like halfway, that still might be enough to kick off and trigger an Mcas reaction for you, but it might not be enough to show up on a lab. So that's one of the reasons tryptase testing can be so frustrating. But back to the Mass Attack article. The reason that most patients with systemic mastocytosis have high tryptase levels is because they have more mast cells, and many mast cells secrete tryptase at rest. This means that even if they aren't activated, they will still release tryptase regularly. The reason why baseline tryptase level is such an important marker for systemic mastocytosis is because it distinguishes mastocytosis from anaphylaxis. Yeah, makes sense. So in short, about 80 to 90% of systemic mastocytosis patients have a baseline tryptase over what is considered normal. This means they tested over 20 ng/ml on 2 separate occasions when they had not had a severe event. They always have a higher level of tryptase. But that's not what we're talking about here. We're talking about mast cell activation syndrome, which is related to and in the same family as mastocytosis, but not mastocytosis. What's happening is this would be the equivalent of having a type 2 diabetic go in and be compared to or treated like a type 1 diabetic and told they don't have diabetes because their symptoms aren't the same. They're in the same family of conditions, but the presentation is different. Doctors need to understand that. Also interesting to note is that there is some evidence that tryptase testing is less reliable in overweight and obese women, and I'm sure that's true from Mass Attack. Some mast cells live in adipose tissues that is harder for large molecules to move through, like tryptase. I can tell you from personal experience that I have less severe reactions, the better health I'm in, and the less that I weigh, which is why I'm working to reduce my weight. So the author goes on to talk about how the assumption is that tryptase is a crummy test. And I, as a community, we kind of agree. But she's not saying that Mcas patients have too many mast cells. She is saying that she doesn't really trust tryptase for detection of reaction anaphylaxis in Mcas patients, to be frank, in anyone. So why do we still use tryptase if it's a crummy test? Because it's not a crummy test for everything. In particular, it is a very good indicator for disease progression for other mast cell conditions. And that means that, again, it's one of the reasons why mast cell activation syndrome can be difficult and takes time to diagnose, because they have to go through a lot of things and we have to have a lot of no's sometimes before we get our yes. But just because we don't have mastocytosis doesn't mean we don't have Mcas. And if we are responding to positively low histamine diet, H1s and H2s, mast cell mediators, mast cell stabilizers, we might have Mcas, because 2 + 2 usually equals 4. Thank you for coming to my TED Talk. Please follow my YouTube channel. Please subscribe, like, hit the notification bell, and links will be in the description box. I'm Pauline from Chronically Spicy, and I will see you in the next video. Stay safe. Just a heads up, not every mast cell activation syndrome patient shows abnormal levels in tryptase testing. I'm going to show you something, and you can pause the screen so that you can take a look at it, and if you need to show it to your doctor, and I will tell you in my experience, I've had multiple doctors completely rule out mast cell activation syndrome in the 15 years it took me to get diagnosed, because my tryptase levels were always normal. Okay, so as you can see here, a normal tryptase level does not rule out clonal mast cell disease. However, the likelihood of diagnosing mast cell disease by identifying characteristic multifocal bone marrow aggregates diminishes significantly in those with tryptase levels less than 20 ng/ml. The bottom line is that I was diagnosed based on clinical presentation, patient history, and not with tryptase. However, a lot of doctors and many that I have had a personal experience with, they look for tryptase only. You could be sitting in there, I have been sitting in there with just covered in welts and hives and a complete and utter physical visual mess, having children point at me asking me what was wrong with my face because of all the welts and hives I was having and experiencing, and doctors still telling me, no, of course it's not mast cell. No, it's not. In fact, if you take a look at my previous video, I have one that shows my worst reactions over the years and all the times that I was gaslit. This isn't to say that every patient who thinks that they have mast cell or suspects mast cell actually has it, because it's very possibly something else. However, I do think it's very important for patients who are trying to self-advocate for mystery illnesses and allergic reactions and such that they can't pinpoint triggers for. I think it's very important for patients to be aware and doctors to be aware that tryptase is not the gold standard that it's being made out to be. So if your results come back as your doctor says you don't have mast cell, it might be time to see if they're willing to look into the research. And if not, it might be time to see if you can search for a different doctor who is willing to look a little bit further and not just look at the test results, but also look at you, your history, and your presentation, because all of that matters. Stay safe and good luck.